Good morning, everyone. Today, we will be discussing sexuality disorders, their causes, diagnosis, and management strategies. Sexuality is a fundamental aspect of human life, and when disruptions occur, they can significantly impact mental health, relationships, and overall well-being. Understanding these disorders is crucial for clinicians, therapists, and anyone working in mental health care. Sexuality disorders, also known as sexual dysfunctions, refer to persistent and recurrent problems with sexual response, desire, arousal, or orgasm that cause distress or interpersonal difficulties. The DSM-5 classifies sexual disorders into four main categories. 1. Sexual desire and arousal disorders. A. Male hypoactive sexual desire disorder. B. Female sexual interest arousal disorder. C. Erectile disorder. A. Male hypoactive sexual desire disorder MHSDD. Characterized by persistent lack of sexual desire or fantasies. May be due to hormonal imbalances, psychological factors, for example, depression, anxiety, or relationship issues. B. Female sexual interest arousal disorder FSIAD. Reduced interest in sex, lack of arousal, or absent sexual thoughts, often linked to low estrogen, chronic stress, trauma, or psychological factors like anxiety. C. Erectile disorder ED. Difficulty in achieving or maintaining an erection sufficient for sexual activity. Can be caused by vascular, neurological, hormonal, or psychological factors, for example, performance anxiety. 2. Orgasmic disorders. Delayed ejaculation, premature, early ejaculation, female orgasmic disorder. Female orgasmic disorder anorgasmia, delay in frequency of, or absence of orgasm, may be related to hormonal imbalances, antidepressants, SSRIs, past trauma, or negative beliefs about sex. B. Delayed ejaculation. Significant delay or absence of ejaculation despite adequate sexual stimulation can be due to neurological issues, antidepressants, or psychological factors like performance anxiety. C. Premature, early ejaculation. P. Ejaculation occurring within 1 minute of penetration or earlier than desired, may be linked to genetic predisposition, anxiety, or hypersensitivity of the penile nerves. 3. Sexual pain disorders. Genitopelvic pain penetration disorder includes vaginismus and dyspareunia. Vaginismus, involuntary muscle contractions in the vaginal walls, preventing penetration. Dyspareunia, pain during or after intercourse, which can be deep, pelvic, or superficial. Vaginal causes include pelvic floor dysfunction, hormonal changes, for example, menopause, trauma, or anxiety. 4. Paraphilic disorders involve atypical sexual interests that cause distress or harm to others. Exhibitionistic disorder, voyeuristic disorder, pedophilic disorder, fetishistic disorder, etc. Sexual sadism. Exhibitionistic disorder, sexual arousal from exposing one's genitals to an unsuspecting person, may be linked to impulse control issues and social isolation. B. Voyeuristic disorder, sexual arousal from watching an unsuspecting person undressing or engaging in sexual activity, often begins in adolescence and may be related to early exposure to sexualized behavior. C. Fetishistic disorder, sexual fixation on non-living objects, for example, shoes, underwear, or body parts, for example, feet, only considered a disorder if it causes distress or impairs functioning. D. Frotteuristic disorder, sexual pleasure from rubbing against a non-consenting person, often in crowded places, linked to impulse control issues. E. Pedophilic disorder, sexual attraction toward prepubescent children typically under 13 years old. Diagnosis requires that the person acts on the urges or experiences significant distress. F. Sexual masochism disorder, sexual arousal from being humiliated, beaten, bound, or otherwise suffering, if practiced consensually, for example, BDSM. It is not considered a disorder. G. Sexual sadism disorder, sexual arousal from inflicting suffering on others, including humiliation, pain, or control, becomes a disorder when acted upon without consent or causes distress. Causes of sexuality disorders. Sexual dysfunctions can have multiple causes, often categorized into biological, psychological, and social factors. 1. Biological factors. Hormonal imbalances, for example, low testosterone, estrogen deficiency, neurological disorders, for example, multiple sclerosis, spinal cord injuries, cardiovascular diseases, affecting blood flow and arousal, side effects of medications, for example, antidepressants, antihypertensives. 2. Psychological factors, anxiety and depression, stress and relationship conflicts, past trauma or sexual abuse, performance anxiety. 3. Social and cultural factors, religious or cultural beliefs about sex, societal stigma and lack of sexual education, relationship dissatisfaction. Diagnosis of sexuality disorders. Diagnosing sexual dysfunction requires a comprehensive assessment that includes medical history, psychological evaluation, and sometimes laboratories tests. Clinical interview. Patient history, onset of symptoms, impact on relationships, physical examination, rule out medical causes, psychological assessment, identify underlying mental health conditions, sexual function questionnaires, validated tools to assess severity and distress, management and treatment strategies. Treatment depends on the underlying cause and the specific disorder. A multidisciplinary approach is often the most effective. 1. Psychotherapy and counseling. Cognitive behavioral therapy, CBT, addresses negative thoughts and performance anxiety. Sex therapy, guided by a trained therapist to improve intimacy and communication. Trauma-focused therapy, helps survivors of sexual abuse or trauma. 2. Medical interventions. Medications for erectile dysfunction, sildenafil, Viagra, tadalafil, Cialis. Hormonal therapy, testosterone replacement for low libido, SSRIs for premature ejaculation, delays ejaculation in some cases. 3. Behavioral and lifestyle changes. Regular exercise, improves blood circulation and mental health. Healthy diet, reduces risk of cardiovascular issues affecting sexual function. Stress management techniques, mindfulness, yoga, and relaxation exercises. 4. Treatment for paraphilic disorders. Behavioral therapy, to reduce compulsive urges. Medication, antiandrogens, used in extreme cases to lower libido. Legal and ethical considerations, ensuring patient safety and public welfare. Case study discussion. Now, let's analyze a case. A 40-year-old man presents with persistent erectile difficulties for the past year, despite having no medical conditions. He reports high stress at work and tension in his relationship. How would we approach diagnosis and treatment? Conclusion. Sexuality disorders are often underdiagnosed due to stigma, yet they significantly impact quality of life. As future clinicians and healthcare providers, it is our responsibility to approach these issues with sensitivity and evidence-based strategies. Thank you for your attention. Any questions?